I was just very pleased to hear quite a few of you are still here. And I'm going to talk a little bit about the expanding of clinical application. And some of them actually very well known, and some of them are kind of like, like snake oil that, you can believe it if you want to. So again, this is over there. DME, I think that, we had multiple paper, and Naomi Lewis is also part of we initiated Diamond study. I want to go applicant, and Naomi is the chief investigator, and that will be reporting soon for DME, and we'll see how that will respond. So one of our original trial comparing DME with conventional laser with about 100 patients was published almost 15 years ago. So it's I would call that a kind of phase 2, then the Diamond is the phase 3, and so that would be over 400 patients. So in DME, you can see here, edema there, and on the OCT laser, one laser treatment only, edema goes away with no visible scarring. And you can see, as you can see there. And often how close can we go? And I think some of American colleagues say they want to shoot the fovea. And, I can shoot the fovea if I wanted to, but I choose not to. And I think that Dr. Philoy already mentioned earlier that, well, if you're going to do 500 spot, if you're doing 496 spot, then, whether does it really matter or not? And I don't think really matter. And so again, you can keep quite close if you wanted to. So this is one of the cases that you can see the very, very close, and you can shoot at it if you really want to. However, that I wouldn't do it on your first case. Obviously do it a little bit first. I can do handbrake turns quite easily on my GT3, and I wouldn't recommend it. Doing handbrake turn by my son, who just got a driving license for the last couple of years. So again, same thing. If you do well, you can do it closer. If you start thing out, make sure that you learn the titration properly, and you can see it work and have no scar. So for mild branch vein occlusion, sometimes that you work very well. And again, you can argue that you can just leave them alone. And I can argue that again and again. And so like this case, you got an edema, there's a few spots of laser, and then they kind of work. So I'll skip through that, man. I think I want to talk about CSC, and I think it was mentioned earlier. And again, most the publication are talking about chronic cases. We are increasingly doing more and more of the so-called acute cases. The good thing about the acute cases, your success rate go up. You get to 97, 98, 99%. The difficulty about chronic cases is that the results are not as good, both on the permanent visual outcome and also that it take longer for recovery. Partly because that when you had a CSC, you're really not sure whether you that 5 or 5 or 10%, that will become chronic CSC. And then even for those who chronic CSC who actually fully recover, getting 20/20 vision back or 6/6 vision back, they still say that they got a large contrast loss. And when we did some work with reading speed and retinal sensitivity, they're significantly reduced. So again, again, the same argument that with you or my eye, whether that I will want to wait for a few months before chronic, or someone that will know what they're doing and should micropulse on my eye. So again, if I find someone that was very good, then I would probably rather that if I develop CSC, I want to treat it earlier. So some of the cases that you can see that's very close to the fovea, and then you can treat it, it'll work quite well, and then you can even closer, and then even this is slightly more chronic cases, and again, just a few spots of laser, it worked quite well. It turned out, however, that we do, over the years, we learned that, yes, small number of sports seems to work, but more sports seem to work better. And we published a paper recently that supported that idea that we probably need to do more sport. The original idea of doing less sport is because we were scared about causing scarring in patients who are actually still seeing quite well, although that they have CSC, and on younger patients and so on. But now that we've done hundreds and hundreds, they've got, many of it, so we are a little bit more relaxed about it. And again, this is really virtually on the edge of the fovea avascular zone. And again, I can say that don't do it on the first case. You've done a couple hundred. This is the kind of things that are really good to play with, and you kind of almost shooting the fovea, and you've been taught so many years not to, and then it's kind of fun to do it. And chronic cases obviously work, and it take more time to work. Sometimes that like this patient, they take we take 2 treatments to work and so on. So again, it kind of work, and you sort of park, and it work. Right? And again, at that time that we didn't do very much, and it kind of worked. So I think that, I probably, you can notice I didn't update my slide, forgot about this 2020 now, so for that DME, small vein occlusion, CSC work. Central vein occlusion doesn't seem to work, and I'm not quite sure why, but again, that is, might be not necessarily a good idea for that. So there's a lot of things that have been published, and again, rightly or wrongly, that seem to be published by the same guy, and then no one else seems to be able to reproduce the result. So again, I have talked to a lot of people for some time now that, when you got like 10 groups around the world publishing it, then you say, yep, you work. When one guy publishing it, and then 4 years later, it's still no one else repeats the result. I mean, it could be fair. You could be the first one. And then, like, to be fair, our first micropulse laser paper, actually 2 years later, before someone else actually published the second result, and then more and more results come out. So, but 4 or 5 years later, you still have no other people have published it. Be careful, right? So, proliferative diabetic retinopathy, we have tried and it doesn't work, and then so we didn't publish it. That you probably should just to say that we published it, we didn't work. But the sad fact of reality is journal doesn't like to take paper that will say that it doesn't work. So, right. And macro aneurysm, and it's been published, and no, actually one ever published it again. To be fair, it works. So, and we think it worked, and then it's kind of all right. No one published again. Still, we haven't done a control trial, data, and so on. But I think certainly something that we have tried it work. And again, another paper about non-responsive neovascular AMD. And again, I'm not 100% sure. I mean, I was convinced that it might work. And then on the other hand, that, there's a paper on a slightly different topic from the CAT study group. Some of you who are retinal will remember that this is really comparing Lucentis against Eylea, Lucentis against Avastin. But in the Lucentis study group, in that study, what they have chose is those who are actually not doing so well, and then look at them 3 months later. And what happened is those who are not doing so well, and then look at them 3 months later, they actually do better. And then you say, wow, what treatment have you done? Oh, actually didn't, because it's a Lucentis study, so they're actually using Lucentis all the way through, and they keep on treating the patient, and it got better. So I think some statistical to norm is kind of a well-known phenomenon. So again, whether this work or not, I don't know. So again, it's something that people have tried. PCV, and PCV in Europe is difficult to do a proper study, and we're trying to encouraging our Asian colleagues to do a study, and there's some data do increasing support that actually work quite well. And in a lot of part of Asia, they're using conventional laser anyway. So, if you are far away, but if you've got a macular lesion, then the only option will be PDT or a lot of injection. And again, in Asia, you need to pay for the injection, and PDT is also expensive, so not everyone can afford it. And then again, micropulse seems to be an option. Certainly, that you could increasingly publication, kind of like presentation coming out, multiple case series that it seems to work. Drusen, and again, I was talking about the 2RT laser can so-called useful for non-intermediate AMD. In fact, when you look at the paper, they actually said that the Drusen did not get better. And they also say that the primary endpoint have failed. And they also then say that, well, if you take this group out, then it kind of work. And so, and I'm not sure how that you can make that claim. And the good thing is actually Robin Guyman, the first author, is a good friend of mine, and she's very open and say that the primary endpoint have failed. So she repeated this several times, but then some other people seem to keep on repeating, say that the laser work. So I'm not quite sure why. However, that we do believe laser can potentially get rid of drusen. And again, that I have been involved in the original drusen laser trial more than 25 years ago when I was first in Moorfield. And we keep on trying to find a better way of getting rid of drusen. And then gradually, eventually, that because of micropulse, subliminal laser, that we can get quite comfortable to doing cases without any scarring. And then we are starting to offering drusen removal for that. And then again, we have some very good result. And gradually that we need to get a randomized control trial to do it as a pilot study. And unfortunately, as always, the NHS takes about 2.5 years for us to get through the paperwork. But last week, we eventually got through all the paperwork hurdle, and then we're going to start this trial in Royal Free. So we had officially initiated, and I think that 2 years ago, I was talking about we're starting to do it, and the NHS keep on blocking us from doing it, and then now that we can eventually get that done. But not only that, so we're going to have a sham control style, proper control trial rather than a case series, and it's happening. So for those who are in London, if you want to, for your patient to come join us on the Drusen laser trial, we're going to do that in Royal Free. And for those patients of yours, if Drusen want to do it privately, we can do it in Otigra. So up to you, whatever you want to do, we can happy to do both. So fine with that. And if you want to learn how to do micropulse laser to get rid of Drusen, I hardly see any patient. Well, I only see patient 1 day every 2 weeks now, so I have plenty of time to teach you how to do it, and then you can do it on your own time. Right. So what else was presented? This has gone crazy. Luckily that it's now 2015 and no one has repeated any of this rubbish. Right. So this same guy say that you work with retinal pigmentosa, Stargardt, GA, whatever, everything. So lysine oil. So you can go and try. And I said in 2015 that if you work, I'll be amazing. And then so for now, 2020, no one has repeated the result because no, it doesn't work. It doesn't make sense to work, but this is how it is. Right? So in summary, in my humble opinion, DME, CSE work really well. RVO, microaneurysm might be, but again, you've got quite a good way of doing it. PCV and Drusen might work. Certainly PCV got more and more data coming out of Asia. And in the West, you might just keep anti-VEGF that you choose, it'll be fine. But a lot of injection might be tough. But in the third world or in the developing world, most of that, in some places the patients have to pay for the treatment and not everyone can afford it, then certainly micropulse would be a potential option, and we have more and more data to come out on that. Drusen removal seems to be something that we are getting to the stage that, yes, I think that increasingly that we can see that it works. Now, whether it prevents CNV or not is still a debate, and also whether that 2RT or SubLiminal laser is a better methodology is another debate. And then now that we are starting a control trial to see whether it works or not. I don't think it works for PDR, and I really don't think that it works for other things. And thank you very much for your attention.